Hello. Hello.
Hello, sir.
Mukul, am I audible?
Yes, sir. Good morning, sir. Hello.
Oh, oh.
Yes, sir.
Yes.
Sir, network issue होउछि.
हाँ परा नेटवर्क इशू बहुत जोर होची.
Yeah. For the inconvenience. Next, I would like to welcome our confidence is a celebration of knowledge, an ardent orator and a devoted caliber personality. Next, with a warm round of applause, please welcome our eminent speaker, Professor Dr. Surajit Sahu, Head of the Department of Medical Science and SOM Hospital. Not only that, Sir has President IPS, Odisha State Branch, C. Boral Award in 2005, and CME Committee Chairman 2006 to 2007. And Sir has 30 national and international publications. Welcome, Sir.
Thank you, ma'am. So, before going to my presentation, I must thank the organizing people and especially Prabhati Madam, Dean, Sam Nursing College, Suchishmita Madam, and Saraswati, and other people along with me. So, the most important thing is that it's visible. Hello?
No, sir.
Visible हो नहीं? Visible? Hello? Hello?
Sir.
Visible?
Yes, sir.
So, visible?
Sir, kindly share your screen, sir. It is not visible to us.
नहीं share कर सकते हैं.
Sir, can we share?
मैं आउथर share कर.
Okay, sir.
Already share.
But
Visible
it is
हो
not
चुकी.
visible, sir. No, sir.
अच्छा. Visible?
No, sir.
Visible होने ना. सेपट तल share
No,
करो.
sir. No, no, मैं share करता हूँ.
ठीक काटे कि मैं आउथर connection देवी की.
Yes, sir.
मत आउथर join कर दो. है राज बता.
आगे.
Okay. So, shall I present?
Yes, sir. Sure.
Okay. So, thanks the organizer. So, it was sorry for this interruption, and it was some problems in this presentation. So, my topic is the comprehensive understanding of Alzheimer's dementia. So, Suchishmita and Saraswati, they both have told how this is very important about this dementia treatment. But the thing is that I just tell it is definitely important, but the importance is also on this the medical fraternity and also to this nursing faculty, because in the dementia there are different types of sufferings. If there is no sufferings, what will be? So definitely the age is a great factor, and when the age is also increasing, age of expectancy is increasing, definitely we are getting some good number of these people to be treated properly. But our science is not up to that advanced that we are not able to treat it very properly. That is the most important thing. Next slide. Next. President Reagan once said, I have three things to tell you. The first is that I have trouble with my memory. The other two, I cannot remember. This shows that he was having suffering from the dementia, and this dementia is most commonly what we see, that is Alzheimer's type of dementia. And next slide, please. And the commonest presentation of this, next slide, please. The commonest presentation of this dementia is, next slide. So the commonest presentation is the definition wise, the progressive impairment of cognitive functions occurring in clear consciousness. So that is the absence of delirium. So the impairment of the cognitive functions and the global impairment of the intellectual is the essential feature manifested with the difficulty with memory, attention, thinking, and comprehension. The other mental functions sometimes also being affected, like mood, personality, social behavior, but it differs from delirium that in the delirium there is altered sensorium and clouding of consciousness. So how the dementia differs from delirium, the definition tells that the impairment of the cognitive functions, but there is no loss of consciousness. Next. Next. So it is visible?
Yes, sir.
Visible?
Yes, sir.
Visible?
Yes, sir.
Visible?
Yes, sir.
Okay. So from history wise, the dementia is derived from the Latin word dementatus. It means out of one's mind. So Celsus was first the scientist in the word dementia who used it is from the first century. So it is not a very uh, young disease, although we just diagnosed this disease about 120 years ago, but the previous scientists have very well told that there is a term known as dementia and dementatus. So these are the scientists this known as Alois Alzheimer's, and this is the patient whose name is August Editor. And Alois Alzheimer first described this is the progressive dementia in a 51-year-old woman, and this woman's name was August Editor, and her histopathological findings were neurofibrillary tangles and Miller foci or plaques. So this is around 120 years back. The scientists have asked about the disease. In DSM-5, the criteria are having the multiple cognitive deficits that include memory impairment, and along with this, aphasia, apraxia, agnosia, and disturbances of the executive functioning. The cognitive deficit must meet the following criteria and also be sufficiently severe to cause impairment in the occupational and social functioning. And it represents the decline from a previous higher level of functioning. So the person was able to do the work properly or has having a good level of functioning and good level of social functioning, occupational functioning, and good level of memory. But after that, he has developed some memory impairment along with this aphasia, apraxia, agnosia, or disturbances of executive functioning. What is actually aphasia? Aphasia is acquired disorder or language due to brain damage. There are different types of aphasia: motor aphasia, sensory aphasia, global aphasia, and nominal aphasia. So motor aphasia is decreased word output. Sometimes people tell like telegraphic speech, prosody of the language is lost, and here the frontal gyrus, inferior frontal gyrus is being involved, and that is known as Broca's area. Sensory aphasia is the understanding is a problem, so comprehension to verbal and retail commands are impaired. Here, the area of the brain is involved is the superior temporal gyrus, that is known as the Wernicke's area. Then global aphasia is feature of both sensory and motor aphasia, but nominal aphasia is the case where there is difficulty to name the objects and remember the name of the people. Sometimes in dementia, people tell that what is your name? I'm not able to remember, but I remember your father's name. So there is the recent memory is impaired, and in advanced stage, the patient may be mute. Then apraxia. So praxis means movement, coordinated movement. So apraxia is inability to execute long coordinated motor activities, assuming intact neurological or peripheral motor apparatus. So ideomotor apraxia, conceptual apraxia, constructional apraxia, and dressing apraxia. So ideomotor apraxia means error when asked to pantomime a movement. So buccofacial movement is a problem. Like if you ask this patient that blow out a mouth, he cannot do it. Protrude your trunk, he cannot do it. Drink through a straw, he cannot do it. Limb commands, like you ask this patient that you just go for a salute or how to use a toothbrush and comb your hair. So he will be not able to perform this type of activities. Conceptual apraxia is the loss of knowledge about the idea of the movements. Like if you tell that they fold a letter, put it in the envelope and seal it and address it, stamp it. But here he will not able to understand the concept how to do it. So here the dominant parietal lobe means we are mostly right-handed, so left parietal lobe is mostly involved. Constructor apraxia, that difficulty in the drawing of geometry figure, drawing of common objects. Dressing apraxia is unable to dress, but unable to dress, dressing apraxia is mostly non-dominant parietal lobe involvement. Agnosia. Gnosis means knowledge. Agnosia is the failure to recognize and identify object despite intact sensory function. So, the individual with tactile agnosia may have the normal tactile sensation but unable to identify the object placed in his hand. He cannot tell that what are the object in his hand, like coins or keys. Prosopagnosia is the inability to recognize the faces, even friends and relatives. Visual agnosia may be reflected in the functional misuse of everyday objects, like he may sometimes urinate in the sink because he is not able to differentiate what is the pan and what is the sink. Then impaired executive functioning. Executive functioning is the problem of this mostly frontal lobe and plan, sequence, monitor, and carry out the complex tasks. The impairment working, dressing, eating, bathing, handling finances, other activities of daily living, deterioration of the self-care, poor judgment and insight, the appropriate jokes are sometimes silly laughter, paranoid delusion, and sometimes there is a disinhibited sexual behavior. So you might have been also heard about that. Those, although the daughter-in-law is doing every work of this or taking care of this old man, but there is some disinhibited sexual behavior approach towards the daughter-in-law, and daughter-in-law sometimes feel very harassed or very embarrassing. So this becomes one of the problem when the frontal lobe is damaged. Epidemiology, already people have told about this epidemiology. So there is increased life expectancy and better control over the infection and medical literacy are all contributing the increase of the elderly population. And how we will be going elder, so is we are going older and older, the expectancy, age expectancy is increasing. So definitely 40% of the people, they will develop dementia when they will be at the age of 90 years, and male to female ratio is almost as far same. And commonest is the Alzheimer's disease, about 50 to 60%. Then next come to vascular dementia, drugs and toxins, intracranial masses, anoxia, traumatic, normal pressure hydrocephalus, and neurodegenerative conditions like Parkinson's disease and other degenerative conditions. Then next, like infections like Creutzfeldt-Jakob, HIV, viral encephalitis, nutritional disorder, Wernicke's, vitamin B12, folate, pellagra, metabolic disorders, dialysis, hyperthyroidism, hepatic insufficiency, chronic inflammation like lupus, collagen vascular disease, multiple sclerosis, Huygens disease. From this is also very important that there are some nutritional disorders like thiamine deficiency, vitamin B12, vitamin D, folate deficiency, and also hypothyroidism. These are all treatable cases, and we can supplement with this with early diagnosis so that we can treat the cases of dementia very well. Then coming to neuroanatomy, in the neuroanatomy, we observe that medial temporal lobe is mostly this memory part of the system. So include hippocampus and parahippocampal region, the core form of the memory system, and other brain regions are also being damaged to functions of memory system. So there is damage to this area. So the acetylcholine are responsible for this memory system. So acetylcholine pathway is one of the important pathway, and there is shrinkage of the nucleus basilis of the menode. So acetylcholine pathway originate in the entorhinal cortex, the nucleus basilis of the menode, and extend to all the neocortex frontals and hippocampal region. The hippocampus has the role in processing information that later stored in the frontal and parietal lobes, and amygdala is also connected with the hippocampus, help to cement the memory events. These are all emotional important. Then how acetylcholine is produced and destroyed? So acetylcholine is produced from this glucose pathway, then ultimately by acetylcholine enzyme A, and by choline, the choline acetyl transferase enzyme, and the acetylcholine is being stored in the vesicles and released to the synaptic region, and ultimately acetylcholine is attached to different receptors, and acetylcholine is regulated by acetylcholine esterase in acetylcholine esterase or butyrylcholine esterase. So mostly acetylcholine esterase is responsible, and when the acetylcholine is released to the synaptic region, it binds to the different receptors like muscarinic receptors and nicotinic receptors. So it binds to the nicotinic receptors, and the nicotinic receptors are responsible for the memory. Then what happens in the cellular region? The cellular region, the mostly there are different secretases are there like alpha secretase, beta secretase, and gamma secretase. By this beta secretase, there is formation of beta amyloid precursor protein, and which is insoluble. So with that, there is aggregation of this beta amyloid protein. There is outside the cells causes aggregation, and that causes injury and excitotoxicity and oxidation. By that, the cell damages or cell death occurs. So due to that cell death, neurotransmitter deficit occurs. But with that, if the beta amyloid precursor protein is having tau phosphorylated, and that is being stored in the neurons, that is known as tangles. So in the left side, there is known as senile plex. Plex is the clumps of this activated, inflamed aggregation of clumps of microglial activation, and also with that damage the formation of this clump that is known as senile plaques. But inside the cell there is the tangles are being formed that is known as neurofibrillary tangles and tau phosphorylated of this beta amyloid precursor protein. And next is the, so in the left side you can see the normal brain and how these gyri are being properly distributed, but in the right side you can see the Alzheimer disease brain and how this sulcus gyri and ultimately overall there is the shrinkage of this brain. So this is the microphotograph of the neocortex from the brain of 62-year-old man of Alzheimer's disease. The silver stain reveals the agyrophilic intraneuronal. So these are this inside the neurons there is the tangles and the clumps are senile plaques. So both the plaques and tangles are seen inside the brain. So in this is very much increased. People may think that it's just a normal senile features are there, but it is not that. It is a comparatively early onset of this clumps and tangles, and which causes more number of neuron damage and person develops dementia symptoms. So this is also same, but pathological hallmark difference of beta amyloid fluctuation, large blue oval in corner, and intracranial clumps are tau known as tangles. So this is smaller blue mass and larger blue oval in corner mass are having plaques. So coming to the diagnosis, how we'll diagnose this case? The first important thing is the history taking. You may miss this history taking, so you should go for the some leading questions for how many days it has been started. Sometimes people will only come to the hospital recently. They will tell that just 1 month or 15 days this he is having this type of problem. But you remember, it is a definite loss of memory from this near about 3 months or 6 months or 1 year, which remains unnoticed, and sometimes it becomes a difficulty for us for the treatment. And there should be a very good and reliable informant who should stay with this patient. Next important is the clinical fixtures, and some laboratory investigations are also very much important, like routine and specialized, like we can treat some of these causes, reversible causes of dementia like vitamin deficiency, and also the CT MRI is also sometimes needed to understand the exact etiology of this dementia. Then most important thing is we are having a very simple handheld tool, about 25 questionnaire, and that is known as mini mental state examination. This is used for the both screening and also for the follow. So this is the MMSE questionnaire. Total marks is 30, and it takes very few amount of time, 10 minutes of time. So maximum score is about 30. From that, what the patient is scoring. If the patient are mild in level 24 to 30 is normal person, but mild is 20 to 24, moderate is 8, 10 to 19, and severe is less than 10. So this is a very simple question. With that scoring, we can know that the person is going to suffer from this psychiatric illness like neuropsychiatric condition like dementia and mostly Alzheimer disease. So this is one of the things is in ORIA. This is almost same that from this questionnaire, if you ask this questionnaire, then if one or two of this question is having positive, then you can go for detailed evaluation of this dementia or Alzheimer disease. And this is one of the important thing, that gradual loss of this as cholinergic neurotransmitters or cholinergic cells happens from this entorhinal cortex and all the nucleus basalis of Menot, and gradually it extends to whole of the brain. So memory symptoms starts very early, but it remains unrecognized for around 2 to 3 years. But when the patient generally come to us, generally 2 to 3 years have been already lost or elapsed, and the patient generally next 3 to 6 years is under treatment. And when these symptoms and this symptoms with this treatment also goes on, and the symptoms and damage of these neurons also goes on, and around 8 to 9 years the patient eventually death. And you remember this important thing is dementia directly does not cause death, and due to some other reason, because there is also some other neurological condition or cardiac condition or aspiration due to fall or due to head injury. So these are all contributing factor causing the person's death. So this is the aggravating factor of dementia, gradual loss of memory. But you remember this slide is very important, that when the patient presents to us around 2 to 3 years have been already patient suffered, and we are in a stage of treating this patient this stage. So accordingly we will plan for the treatment. So symptom progression in the Alzheimer's disease in mild cases of dementia. Before that, MCI is known as minimal cognitive impairment. Here, actually, person do not have so much of cognition problem, but there is a very normal functional activities and having very few amount of objective and mild subjective memory loss is there. In mild Alzheimer's disease, there is forgetfulness, short-term memory loss. The person asks repeated questions. So you will get the same question that he is asking repeatedly because he is not able to remember. How is interest or loss sometimes associated with this irritability and also depressive symptoms and impaired instrumental functions and anomia. Naming of the objects he forgets. Then in the moderate Alzheimer disease, it is also risk. There is progressive cognitive deficits are there, and here there may be have aphasia, dysexecutive syndrome, impaired activities of daily living. And this is very important that in these conditions are important for the safety and security purpose, because here the patient forgets to road to his house. Here the patient forgets that the switching on the gas and he forgets it, so there can be fire in the house. So this is one of the very important thing. Next is severe Alzheimer's disease. There is agitation, altered sleep pattern, and total dependence on the caregiver for dressing, feeding, and bathing. In moderate severe cases, there is also stress to this a caregiver. So as a caregiver, because patient will come to not to the directly to the hospital, they will be accompanied with the caregiver, and these will be the problems. So this is a slide showing gradually how the general cortical atrophy over the period of 3 years, and there is the prominent ventricular enlargement and prominent hippocampal atrophy is there. So serial that person is having followed up over the period of 3 years, and serially how there is shrinkage of the brain matter and also the memory centers. The treatment Alzheimer's disease is also one of the difficult part, but the first important thing is that we should understand the disease process and also what next we can go for this treatment planning. First is that to modify the risks that slow the course of the correct reversible causes of dementia. So with this investigation, that whether this is a cause of reversible cause of dementia, like you can go for glycemic proper control and hypertension treatment, vitamin B12 folate deficiency, and hypothyroidism treatment. Then treatment of this cognitive symptoms of dementia with medications. Then next step is the treatment of associated symptoms and behavioral disturbances. This is a very difficult part of this treatment, and due to this reason, generally patient come to the hospital by this attendants or caregivers. So here, antipsychotic, antidepressant, mood stabilizer, benzodiazepine, and anxiodiuretics are used. Then non-pharmacological interventions like health maintenance activities, with exercises, routine, socialization, recreation, daycare centers, and Alzheimer association with some clubs and other activities to be done. And the education and alliance between clinician and family members and other caregivers are extremely effective if we can modify the treatment planning or we can properly educate these caregivers. Then medications mostly used like cholinesterase inhibitors, donepezil, rivastigmine, NMDA antagonist, memantine, antioxidants, vitamin E, hormones like conjugated estrogens, ginkgo biloba, acetylcarnine, piracetam, and anti-inflammatory like because there is a chance of inflammation in the brain, so NSAID may be used. But these medicines are not the cure for the patient. These may halt the process of this disease to some days. So there are different are there, and along with the medicine side effects and other things to be explained to the caregiver. Then important thing is that health maintenance and general medical treatment is the gradual process. So as Alzheimer's disease progresses, various conditions develop that may lead to death, such as septicemia, pneumonia, upper respiratory infections, nutritional disease, pressure sore, fracture, and wounds. So, manage of these conditions are very important. Then, alliance with the caregiver is also very important because the caregiver to be also to be counseled and properly educated accordingly the management. So if these people are being properly doing their activities in a proper time, also doing all the activities during their time, the healthy body becomes healthy mind. Some studies show that exercise can slow some cognitive decline. And next is the study of norms suggests that the high linguist activity and early life correlates with the lower Alzheimer's disease. So those people who are actually being engaged in their activities and also they are maintaining their reading activities, maintaining their writing activities and exercise activity, so they less suffer from this is just like disease atrophy. There's a less suffer from this progression of this Alzheimer disease. For that reason, we ask this patient to be properly engage in all other activities accordingly, hobbies and other things, and with their friends and family members. So this is definitely a helpful activities. Then, if you see about our Bollywood and Bollywood, I remember two different movies. One is Black, where Amitabh Bachchan has suffered from dementia. Very beautiful movie, and how he has forgotten how he was a very good teacher, excellent teacher, but how he has forgotten gradually the name of his student and the road to his house. So this is very much important. The next movie was uh, You, Me, or Hum. In that also, the causal dementia and Alzheimer disease, it was very much well treated by this, well depicted by this protagonist. So, in future, what will be the coming treatment? Actually, the research is going on that we will just stop the secretase inhibitors. If the secretase inhibitors will be there, then there can be production of amyloid protein will be less, and beta amyloid vaccination may be there. Vaccination, this breakdown of accumulated amyloid will be there. Gene therapy and fetal stem cells, but these are all in research activity. This may will come within some days in some future. So this is one of these treatment approach may come in near future, and definitely we should be hopeful and to increase the life of the people and along with their quality. So last my slide is take home message. The current therapies for the patient with Alzheimer's disease may ease symptoms by providing temporary improvement and reducing the rate of cognitive decline. So early diagnosis is also very important to get the benefit from the treatment, thus substantially delay the onset and modify the progression of Alzheimer's disease. Because if we can treat the disease early, then definitely will halt to the process to go to the severe form very quickly. Although disease and old age are inevitable, the people should be engaged their activities which halt the progression of their cognitive impairment or cognitive decline. So treatment of our today's discussion is to increase the quality of life of both patient and caregiver. So there will be definitely the disease will be there with the old age, but they have might have been thought that the disease will be in near future have some vaccines or some treatment so that there will be no accumulation of this insoluble beta amyloid protein, which is the harmful protein, and we can cure the disease. So cure definition may come after that. So lastly, I just tell that this is the photograph of Lord Jagannath. So when in Corona, everybody was thinking that only God will save us from the disease and other things. This is also very important that I remember during our younger time, and there was the different Bhagavad Tungi and Bhagavad evening were there, and where the old age people were sitting and discussing about this Bhagavad Sandhya and also discussing about Gita, and definitely that was the place where they were also fun making and also mixing with these other people, and the disease process was definitely declined. So this was also one of these approach from the spiritual aspect. Thank you all, and I just thank the organizers to give me to speak about few words about on this occasion. So thank you all.
Thank you very much, sir. Students, if you have any doubt, any queries, it is an open field. You can ask any question to sir.
So it was audible over the period.
Yes, sir, it was audible.
Okay, thank you. So there may not be any question perhaps. So just allow.
Any doubt or any questions, students? I think it is very clear to all of you.
Okay, one question is there. One question was there that what is the main difference between the vascular dementia and Alzheimer dementia? So Alzheimer dementia is most common cause of dementia where there is formation of beta amyloid proteins. But in vascular dementia, the dementia is cause is the vascular origin. So in like diabetes, there is microvascular angiopathies are there, and in the hypertension, there is different types of microangiopathies are there. By that, the cell of the brain has been damaged, and we suffer of this dementia. So important thing is that Alzheimer dementia is a gradual onset, but vascular dementia is mostly sudden onset because of the vascular cause. So blood supply is cut, then we suffer from the dementia due to damage of this brain tissues. And the most prone problem is the diabetes and hypertension. When there is damage to this brain microvasculature, then we will develop dementia. And if you see, today it is not only the Alzheimer dementia. We always get mostly because in India, the people suffer from diabetes, blood pressure comparatively in the early age, and we get both the types, mixed type of dementia very commonly, both vascular and Alzheimer, mixed type of dementia.
Thank you, sir, for giving a clear clarification between vascular dementia and Alzheimer's dementia. Any questions, students? So I think there is no questions and no doubts from the students. So without delay, we would like to proceed our next session. One such an eminent and vast personality and a key person of knowledge, I would like to invite our another eminent speaker, Dr. M. Srinivas, Associate Professor, College of Nursing, All India Institute of Medical Science, New Delhi. Welcome you, sir. Not only that, sir has completed Diploma in Pharmacy from Swami Vivekanand College of Pharmacy, Tamil Nadu, BSc Nursing from Rajiv Gandhi University of Health Sciences, Mangalore, MSc Psychiatric Nursing from AIMS, New Delhi, PhD in Psychiatric Nursing from INC Consortium, currently enrolled for fellowship in FAIMER International Institution of Leadership in Interprofessional Educations, and published the best-selling The Target High books for the nursing competitive examinations. Published several papers in national and international journal of reputations. Sir has attended 4th and 6th international conferences on workplace violence in USA and Canada with ICMR International Travel Grant and full sponsorship with the conference organizers. Welcome you, sir.
Thank you very much, Tanya, for the introduction. Am I audible there?
Yes, sir.
Am I audible over there? Okay, let me share the screen first. Okay. I hope my screen is visible and I am audible. Please confirm it.
Yes, yes, sir. You are visible and audible.
Yeah, right. So, we are observing the World Alzheimer's Day today, and the theme is, already, together we can ensure no one faces dementia alone. I'm happy that my topic is on line with the theme to speak on the theme. I'm happy to be invited to speak on this theme, that together we can ensure no one faces dementia alone. And especially we focus on awareness of nurses today. Of course, the importance and the we emphasize teaching the community where the dementia people lives has to be educated and made aware, so that dementia people do not feel isolated and they are not stigmatized, so that they live a better part of their life. That's a actual goal. But to start with, first of all, we would like to make aware our nurses first. So nurses must be aware at all levels. Nurses works at primary healthcare level, secondary or tertiary level, all levels. The nursing workforce is an inevitable and important workforce. So educating and training the nursing workforce on this dementia care is very important to go further. So actually, this is the tweets about by World Health Organization Western Pacific and by Ministry of Health today regarding World Alzheimer's Day. And you see, WHO Western Pacific have tweeted, together we can create a dementia inclusive communities. We can create a dementia. See, dementia people with the dementia also a part of the community. So we have to make the community which is inclusive of dementia patients. We have to make their life better. We have to give their space and make their life better. That's the actual goal. Establishing programs and services for older people will help communities thrive while protecting and promoting the health of those with dementia. That's a tweet from WHO Western Pacific. And also they add, a dementia inclusive community begins at home. At home, the family members have the primary responsibility to accept and care the dementia people. The care starts from home, then you can expect from the community. Always we say charity starts from home. So the family members should take care of dementia patient well. They have to accept the dementia patient. They have to understand their need, and their needs are different, and they have to recognize their need and meet the needs. Then only they can expect from the community. That is what called dementia inclusive communities. Okay, the Minister of Health in India tweeted today on World Alzheimer's Day, let extend our support to people suffering from Alzheimer's disease and dementia. You all know dementia is an umbrella term, and Alzheimer is the most common cause of dementia. So that's why we focus on this dementia as a whole for this particular topic. So every September, people come together from all around the world to raise awareness and to challenge the stigma that persists around the dementia. So I think this is the 10th year, that is September 2021 is the marking the 10th year of this vital global awareness rising campaign. And the theme of this year actually highlights the need for all of us to reach out to people with the dementia in our community and let them know they are not alone. That's a key message even from this presentation, as well as the theme is that they should not feel alone. They should not we have the responsibility to include them, to make an inclusive dementia inclusive community, so that they do not feel let alone and they do not feel alone. We talk about alone, why we should not let them feel alone, why we talk about this loneliness very much in dementia. So let us say, why can it feel so lonely for dementia patients? Loneliness is a multi-dimensional factor when it comes to dementia. It is a multi-dimensional factor. We'll see what are those. The person on the journey with the dementia experiences it. The person with the dementia actually experiences this loneliness. Though sometimes surrounded by people, individuals with the dementia can still feel so alone. So don't think that people surrounded by them does not make them feel alone. They may be living in a joint family. They may be living with people. There may be people surrounding them all the time. But that does not mean they are socialized. That's a difference between. You see the next point. There is it appears it is the feeling of loneliness and not actual social isolation. There is a difference between social isolation and loneliness. Social isolation is nothing but lack of social connectedness. You have less social connections with people. But loneliness is you feel alone even in the presence of people. So these two are two different things. Don't get confused. So people may live with people in a joint family. They're living around people all the time, people around them, but still they may feel lonely because they are lack of confidence. Their needs are different. They are apprehensive that they go out, they will not be able to come back to home due to the memory loss. They are afraid of going out. They are afraid of doing things. So these are the things make them very, very apprehensive, lack of confidence, and they feel alone. And this loneliness alone can lead to the development of dementia. That is the sad part of the story. The loved ones around them feel it themselves, and they feel for the person they love as they witness loneliness in. The loved ones, those who are with with the dementia, particularly those who are care workers, those who are 24 hours a day taking care of family carers, those who are taking care of these patients 24 hours a day, and loved ones around them feel it themselves, feel loneliness themselves, and they feel for the person they love as they witness loneliness. Loneliness and isolation are known to accelerate the deterioration of cognition and mood. So these loneliness and isolations are associated with the accelerated deterioration of cognition as well as the mood. And international, national, and local restriction, laid on restriction on the people with the dementia have imposed a layer of protection isolation. They comes under protection isolation. Even in the family, they'll be protected, isolated. You cannot go out. If you go out, you cannot come back. So there will be a lot of protection isolation which will be imposed on them, which are some are broadcast, some are obvious, and some are hidden, and some are complex. So coming to the dementia facts, some of the facts about the dementia. Dementia is about dementia and its the course of disease and different phases are already discussed, so I don't want to go into the disease, but just before going into the nursing care part and what are the role of nurses in dementia care, how we can make a life of the dementia patients better, will be before discussing that. Just we need to see the burden of the disease. What are the facts? So dementia is not an inevitable part of aging. However, as our population ages, the number of people living with the dementia is set to increase. You all know that it is associated with aging. So number of people, see, according to the census of 2011, 5.5% of the Indian population is elderly, that is 60 plus. So we have close to 140 crore population. Even 5% is 7 crore, and it is keep growing in the, it is expected to grow much more in the near future. So in next decade, in 10 years, our elderly population will be much more than even most of the country's individual population itself. Even now our elderly population alone is more than population of many of the countries. So the burden, see, even if you take 1%, prevalence of dementia, the number of people with the dementia will be much more. Okay, as the age increases, prevalence of dementia increases. For example, nearly 20% of people, you see, I just stated an example of 1%. 20% of the people above 80 suffer from dementia. For example, if you have 1 crore population above the age of 80, the 20% means 20 lakh, that is 2 million population with dementia. So mean age of presentation is relatively younger at 66.3. So the average age of presentation of dementia is actually a little over 65, that is 66.3 years. Unlike the Western countries, in India, most of the elderly people live with their families, and most patients with the dementia are taken care of by the families. That is the one positive point, because in Indian culture, most of the elderly people are not left alone, because still we are living in a country where leaving the elderly person into the old age home is considered to be sin. In most part of India, even now, leaving an elderly person, when you see people living abroad, when there is no other way, they leave it in the old age home. But when your family is here, when you are living in a joint family system, or even in a nuclear family system, leaving your parents or elderly people in the old age home just for taking care, just that you are not able to taking care, is considered to be a sin. That is a positive point that we are in, so that they are not let alone. So unlike West in India, most of the elderly people are still taken care by the families. But I remind you, the things are changing very fast. I'll discuss about it later. The things are changing very fast now. We are adopting the Western culture. Maybe our DNA is Indian, but we are trying to adopt the Western culture. That's leading to disastrous changes even in this care of elderly people, that we will discuss later. With the increasing elderly population and reducing joint family system in our country, dementia poses a great challenge. Levels of nursing involvement in dementia care. In what levels? And as a nurse, already I pointed out, we involve in primary, secondary, as well as in the tertiary care. So all nurses are involved in awareness, alert, and dementia friendly. So all nurses must be aware of dementia. They must be alert of all the signs and symptoms of dementia, and they should know what are the dementia friendly care. Then coming to nurses working with the people with the dementia in all care settings like primary, secondary, community, and independent and social care. So they must be actively involved. They should anticipate and understand and respond to needs of dementia patients. And comes to the specialist skills. The specialist dementia nurses. Specialist dementia nurses are usually palliative care nurses or specialist dementia nurses. They are in the position to train others at the lower level, like in the second level, those who are nurses working with the people with the dementia. They are in the level of, first of all, taking specialized care as well as training people, so that they are made to, they are trained to take care of patients with dementia. So briefly about different settings in which the dementia care and how it is been progressing now. First of all, home-based care. Considering India's social structure and culture, which I already pointed out, immediate family members are the main carers of older people in home in India. But the strong cultural tradition of giving respect, bearing the financial need, and taking care of older members of family are changing very fast. Not yet changed, but it is, I should say that it is changing very fast, and very soon there will be high need of assisted living facilities or institutions or some form of community support system for long-term care of demented people with intensive care need. What I am saying is that things right now is okay. People are taken, most of the people are taken care at home, even with the dementia. Sometimes even these conditions go unnoticed and undiagnosed because family takes care of themselves. They do not even bring to the to the notice of healthcare team so that they are given professional care, but most of the family take care of themselves. But very soon there will be need of assisted living facilities and institutions and specialized care centers, community support system for these people, because things are changing. Sorry. Coming to institutional long-term care, assisted living facilities or institutions which provide long-term care are few in India, and the exact data on number of quality of these elderly care facilities are not even available. So there are some old age homes. According to Helpage India, there are 1300 plus. The census is very long, dated long back, so I do not have the recent data or very latest data. Somewhere around 2013 data says that somewhere around 1300 plus elderly homes are there, and but paid and private rent facilities are expensive. There are some of the government setups, some of the setups run by NGOs and missionaries, which are which are affordable and people can leave the elderly there for caring. But paid and private run facilities are expensive and are usually located in urban and semi-urban area. Note this point: it is usually urban and semi-urban area, but the disease burden is more in rural area. 70% of the country population, particularly in India, 70% of our population lives in rural area. So we need settings, community settings over in the rural area, so that it is taken, that they are taken care well. For this, they cannot travel to urban area for this particular purpose. So all the facilities are concentrated in urban and semi-urban area, which cater to only 30% of the population of the country. But I tell you, more than 90% of these facilities caters to the 30% of the population lives in urban and semi-urban area. Rest of the 10% of the facilities are for the rest of the 70% of the population. That is the kind of inequality in the distribution of these care centers. A majority of the old age homes are concentrated in the developed states of south and western part of India, not in northern and northwestern part of India. So these are not easily accessible and not affordable to needy aged people. Actually, that's what the equitable distribution there. Okay, we have care centers, we have old elderly homes to give professional care, but these are not equitably. There is no equity in distribution of these centers across the country. These are concentrated in either certain part of the country, and it is heavily concentrated in urbanized and semi-urbanized areas. Coming to hospital-based care. Acute care services are usually designed in a way to address patients' acute medical problems. So in hospital, usually the entry point of all the elderly patients are emergency department. Unless they they get into some issue so that they need immediate emergency treatment, usually they are not taken to the hospital proactively. When there are symptoms of dementia, when there are other cognitive impairment, symptoms of cognitive impairment, memory loss related any issues and problems, the family members, neither the patient or the family members, not interested to go to the hospital. So acute care services are usually designed in a way to address when there is an acute medical problems, they will be treated. The primary aim is to provide fast and effective services in assessment, diagnosis, intervention, cure, if possible, and discharge. And people with the dementia attend acute care centers for the same reasons as older people generally. So usually they all come to the acute care centers for the which I have already discussed. Regard. The Ministry of Health and Family Welfare of India has launched a national program for the healthcare of elderly, that is NPHCE, during 11th 5-year plan period to address various health-related problems of elderly people. A community care program for older people with a functional impairment, that is called Pariraksha, a joint venture by the District Panchayat in Malappuram district of Kerala, by a District Panchayat in Malappuram district in Kerala state, which offers support and guidance to all chronically and incurably ill patients in the district, has been highly successful in community care giving for disabled elderly. This is one model which is tested like a Pariraksha joint venture in the Malappuram district of Kerala, which was found to be very useful and successful in community care of disabled elderly. Finally, the rehabilitative mental care. So rehabilitative care in the different stages of dementia is a vital need in managing the behavioral symptoms and other associated physical limitations. So when you read psychiatry, it is in F00 to F09 under organic mental disorder. This dementia is classified. So they have behavioral issues. They show behavioral symptoms due to dementia, which has to be taken care. Specific occupational therapy intervention program is very effective in increasing the mood, functionality, physical performance, and overall quality of life of the cognitive impaired elderly. This was found in the Prakash et al. Study in Prakash et al. Study published by Prakash et al. In AIIMS geriatric department. Coming to the the role of nurse in dementia. This is most important. What is the role of a nurse in dementia care? First of all, understanding the unique experiences of a person living with the dementia. This is what we call it empathy, right? Self-understanding as a tool, and put yourself into others' shoes to give holistic and comprehensive care. So try to understand the unique experiences of people living with the dementia, memory loss. They are not able to live a life as like others, and they have to lead a compromised life. So they are the loneliness crippled in. Though they are living with the people, they feel lonely. They feel disconnected from the people. So their experience is very, very unique. Okay, that you need to understand while caring them. Building and maintaining a relationship with the person and their family. It is not only the person as a whenever you plan your nursing care, that you have to include their family in this, because without family support, the goal will not be reached, or the care there will not be a successful outcome. So include actively the family members in your care plan, as well as you have to build a trusting relationship between you and the patient, as well as with their family. Respecting the person and their family and treating them with the dignity and compassion. That is most important. They already feel stigmatized. They feel low. They feel lonely. So treating them with the utmost dignity and compassion, taking account of their culture. So see how you talk and how you interact with the people should be according to their cultural perspective. I don't need to explain more. You all know about transcultural nursing. So you have to give a culturally adaptive care, and dementia patient is no different from that. Recognizing the person for who they are and taking the time to understand their life story, interests, preferences, wishes, social networks, and strengths and abilities. See, dementia care is not like emergency care, trauma care, or you are caring for a person in ICU and discharge. It is going to be usually a long-term care. So building a relationship, building a good IPR, nurse-patient relationship, understanding their needs, their unique experiences, listen to their life story, know about their interests, know about their preferences, their wishes, their social networks, their support system, internal and external support system. What are their strengths? What are their weaknesses? What are their abilities? These are all the information which help you to give quality care to the patient with dementia. Developing person-centered outcome. Always focus on the person-centered outcome with the person and their family, and that recognize and anticipate the phases of the condition. Later we'll come to what are the different. See, I'm generally talking about your role as a nurse in dementia care, but the role is totally changes, or sometimes the role is totally different in different phases of dementia. Usually in dementia phase, first of all, there will be symptoms. They are not even diagnosed to be a dementia. Then they get diagnosed. Then they understand that they are in dementia. So there are different phases in which your responsibility as a nurse while taking care of the patient with the dementia keep changing, and it's dynamic. So that we will discuss later. Promoting and providing a dementia friendly environment, that is very important. You all know therapeutic milieu. So dementia friendly environment, providing a dementia friendly environment is very, very important in dementia care. Seeking alternative sources of support, including non-medical services if unable to provide direct assistance. When as a nurse you have a limitation, particularly these are from Western literature. Even in India you are more I don't call it, you have a limited scope of practice. You cannot prescribe any drug. You have less independence in deciding any treatment, and you depend on medical personnel to prescribe any treatment. You will be only the care provider, but you will not be able to decide what care is appropriate at point in time. You see, of course you can decide nursing related care even here, but most of the treatment has to be prescribed by the physician. That is true. That is we have to accept. Because in Western countries, there are nurse practitioners, even nurses working in community have a lot of freedom, and they can decide many of the they can make a decision in many of the care related thing. So here seeking alternative source of support when you are not able to decide the treatment or any intervention, including non-medical services. Now taking prescription or order from medical professional is different. Even sometimes you may require a non-medical services like NGO, sociology, social worker, or some social voluntary organizations. All those things you may need when they require, like memory related services. All those things are available. So when you are not able to provide such support, then you can seek non-medical services when you are unable to give. Identifying and reporting any potential form of abuse that the person with the dementia may be going through. It's very important. You should be able to identify and report any potential form of abuse. So the patient, those who are taken care at home, may be subject to abuse. They are not able to tell outside. As a care nurse, your responsibility to identify and report to the appropriate authorities to prevent and take appropriate action on these abuses. That's very common too, because in some families abusing the elderly, they think that it is their right to abuse the elderly people because they think they are protecting, but in the name of protection they abuse, sometimes neglect, sometimes restraining them from going out of the home, and their needs are not fulfilled, so that is abandonment. So there are different as a person, I myself conducted a PhD dissertation research on elderly abuse. So I met 432 people living in community and interviewed all 432 people and spoke to them. So I know that many of the people undergoes type of abuse, any of the abuse, neglect, abuse, mistreatment or abandonment. Even the family members, even they do not even aware that they are abusing. They think that is their right, and they are thinking they are protecting the elderly person. So that's a sad truth. So nurse should be able to identify this, and either you can educate the family members, or if it is not possible, then you can report to the appropriate authorities to prevent these kind of things. A new vision for the nurses' role in dementia. Apart from whatever the routine vision, there are new vision. So the nurses have a key role in providing health education to promote healthy lifestyles that reduce the risk of developing dementia and support people to remain active and live well. So we have the responsibility to educate, to promote lifestyle, and to reduce the risk of developing dementia in healthy population, and support people to remain active and live well. So you see, usually people who remain active, there are studies who support people, those who are very active, those who are employed and they are active. There are it is associated with less incidences of dementia. Nurses work within an interpersonal and psychosocial model, understanding the effects of dementia and having the skills to communicate with the individuals and their family and cares. All nurses undertake dementia education or training to support development of their knowledge, skills, and expertise. Nurses should be aware of relevant safeguarding protocols and how to refer vulnerable adults. That's what I was talking about elderly, the abuse also. Even if you are able to identify some abuse in the elderly patient when you are giving a home care, or the patient is brought to the hospital setting, you identify some signs of abuse, some kind of scars or some marks in the skin, you are able, you suspect abuse, but you should be able to know, you should know that how to what are the protocols in safeguarding them, where to refer, and these will ensure that people with the dementia have safe, effective, and compassionate care. The nurse's role includes welcoming and working in partnership with individuals, family, and carers, respecting and diversity and cultures. This is kind of interpersonal role. The nurse's role varies in intensity and action depending on the phase of dementia and the person's specific needs. We'll talk about the phases later. Nurses have a leadership role in developing dementia-friendly communities and reducing stigma. Nurses have a critical leadership role in supporting and promoting dementia-friendly communities. These are the leadership role in dementia care. So, dementia core skills education and training. What are the dementia core skills education and training? There are 3 tiers of training framework given by UK. Alzheimer's framework. UK Alzheimer's Society in UK, they have given a training framework of skills education and training for the nurses in not only for nurses, for entire healthcare, including nurses. So there are 3 tiers. In tier 1, dementia awareness rising in terms of knowledge, skills, and attitudes for all those working in healthcare and setting. This is what we are focusing on this World Alzheimer's Day. Dementia awareness rising in terms of knowledge, skills, and attitude for those who are working in healthcare settings. Not only that, also family members and the community and public. So knowledge, the tier 2 is knowledge, skills, and attitudes for roles that have regular contact with people living with the dementia. This is what the second one. The people who have regular contact with this dementia people also has to be educated on knowledge, skills, and attitude part. And finally, enhancing the knowledge, skills, and attitudes for key staff experts like dementia care nurses. Key staffs working with people living with the dementia designed to support them to play leadership roles. First is nurses or healthcare workers who is working with the dementia. Second, knowledge and skills for the people those who are closely associated by living with like family members and the community in which the dementia people are living. The third, it is about the leaders, the experts of experts of dementia care, and the leaders those who are involved in training, all those things also has to be made aware and about knowledge, skills, and attitudes. This is what the pyramid is. So all 3 levels has to be made aware. We come to the critical aspects of nurses' role within the dementia phase 1. The first phase, phase 1 is all about when the memory or other problems prompt concerns. So when the patient is not even diagnosed for dementia at this stage, but the memory fades and the other problems started surfacing. This is the stage. Here the role of nurses must be aware and alert to the signs, symptoms, and progress of dementia. Nurses should understand and take account of other conditions a person may be living with, maybe comorbidities. The person may be living with other disease like diabetes or hypertension, other cardiac disorders. So only you cannot just give exclusive or care specific to only to dementia. You have to give a holistic care. So you have to consider what are the other conditions patient have and access appropriate support. Nurses should be able to access appropriate support system also, and provide leadership and support to the development of dementia friendly environments. Dementia friendly, this is what the tweet by WHO today. Dementia inclusive community. The community should include dementia patients as a part of them. So provide leadership role. You have to provide a leadership role and a support to the development of this dementia friendly environment. So then only see stigma starts from a person. Stigma starts from family. First of all, the family members stigmatize their elderly the dementic patient with the dementia at their home, and how can they expect the community will not stigmatize the person? So first of all, the family should accept. Then only you can expect the community will include or accept the person with dementia. So you have to play a bridging role. You have to you have to support them. You have to educate them. You have to play a role by showing a compassionate care to the patient with the dementia. So compassion and understanding to those expressing concerns about memory, communication problems, and other possible signs of dementia. This is the stage the signs started surfacing. Okay, this is the phase 2, the critical aspects of nurses role in phase 2, where learning that the condition is dementia. This is the stage the patient learns that it is a condition of dementia. All nurses provide sorry for the spelling mistake. All nurses provide a compassionate support to people with the dementia. Nurses are prepared to advocate on behalf of the person with the dementia and or their family and carers. So we know nurses have an advocacy role. So you have to advocate for the family as well as the person, the patient as well as the family. Nurses know how dementia might affect the person, their family, the family and the carers. The nurses recognize the person as a unique individual and citizen with the strength as well as the needs. So any individual have their strength and needs, not only dementia patients. So nurses recognize that a person with the dementia also have unique individual, is an unique individual and a citizen with the strengths as well as some weaknesses, and also have some specific needs. And nurse know how the cognition might affect any coexisting conditions. So if the patient is cognitively impaired, how it will affect some coexisting condition in the patient. Coming to the phase 3, in which learning more about dementia, self-management and options for treatment, care and support. This is the stage the patient accepts and knows that he has dementia, he or she has dementia. And this is the third phase, in which how to manage the condition, what is the self-management, and what are the options for treatment is explored, and care and support is provided. In this phase of dementia care, the nurse's role is to provide information. So information is wealth. The nowadays, especially if I apply into this current situation, I see the patient who comes into ward with the diabetes, who is diagnosed with the diabetes for 5 years. They explore Google, and they read a lot of WhatsApp forwards. Now they get graduated in WhatsApp University, Facebook University and all. They have a lot of misconception, and they misread. They Google and they read unauthentic sources. They read gray articles. They do not read only scientific articles. They are flooded with wrong informations. So they have a lot of confusions. They think they know, but they are not actually. So what information provided by trained healthcare professional by nurses are actually authentic, scientific and evidence based. So provide scientific evidence based information and advice about living well with the diagnosis of dementia. There will be always for these chronic conditions, there will be a lot of myth which they believe. So that the nurses have the responsibility to discourage those and provide right information. Work in partnership with the person to identify needs, preference and outcomes. Know about local services, community resources and opportunities. So first of all, nurse should know what are the local services, what are the community resources, and what are the opportunities left for the patients. Because you may not work in the same situation, same community, you may switch community, you may go to different place to work with dementia patient if you're if you're involved in dementia care. So you need to explore and learn what are the local services, community resources and in different area before you put yourself. But that's called orientation for the nurses themselves. So support the person to overcome barriers and stigma. Ensure that the person and their family and carers know whom to contact in a crisis. Fourth phase. In this phase, getting the right help at the right time, preventing crisis and managing together. So that may be a possibility of getting into the crisis situation. What is crisis? When they are not able to manage themselves, they need external support to care for themselves. So preventing such crisis are the major goal here. So work in partnership with the client. I'm sorry. Work in partnership with the client, the family, carers, and colleagues to plan care, identify possible crisis situations, and establish strategies to preempt or manage those crises. So you need to identify what are the possible crisis situation may emerge, and you have to establish. There should be a plan in hand if such crisis arises, how to manage that. You always have to work in partnership with the NGOs and voluntary organization in care of patient at this stage. Support the person to access psychological and other relevant therapies which may be useful for the patient at this stage. Liaise with the relevant service. Here you play a role of liaison nurse. Liaison nurse, you know that you will associate and you will get associated with other healthcare professionals like doctors, social workers. So liaison is making relationship and give comprehensive care with interprofessional. It is nothing but an interprofessional team which provide care to the patient. So ensure that physical health and care needs are identified and met. Then in phase 5, getting help to stay at home. If needed, move to alternative care accommodation met. You see, always to be taken care at home, you need to take help, or if the resources at home also are not enough, and there should be a plan to move to alternative care accommodation facilities if the care needs are not met at home. So at this stage in the phase 5, because the patient get more severe here, the work with relevant health and social care and voluntary sector services to frequently assess the need for move them into other facilities. Wherever possible, work to prevent admission to an acute hospital. So you always have to work in a manner that you should prevent admission into the hospital wherever possible. If it is not possible, it is needed, you have to admit, but you have to work in a manner that they should not you should prevent admissions. Prevent admission in the sense you should prevent some certain complications which require admission. That's it. Work to enable safe, timely discharge from hospital if they are admitted. Make sure that there is appropriate community support. Here also your role is very important. You have to mobilize the community support for them. Support the person and our family and carers in decision making. Finally, the last phase, which is sixth phase, receiving care, compassion and support at the end of the life. At the end of the life, they require the support. At this stage, what is your responsibility? Work to understand and record a person's wishes, that is a will, you call it, and preferences for end of life. Everyone will have the preferences for end of life, where to they prefer some place where they should take their last breath, and where they should be buried or cremated. They will have a lot of, some people maybe working in a different place, migrated for work purpose, they wanted to be transported to the native place to be cremated. All those wishes are you have to take care. If possible from your side, you have to mobilize and you have to convey this to appropriate people to make it possible, including where they would like to die, and provide support to help achieve this. Your responsibility to provide support to help achieve these preferences wherever possible. You cannot just fulfill all their wishes, but wherever possible you can help. Understand potential difficulties in communicating pain and distress, and work with medical colleagues and other to ensure effective pain relief. That is also very important when they're during end of life. Pain management, you have to work closely with medical people to take care of this. Ensure good communication between palliative care, primary care and other relevant colleagues and family and carers. Support the family and carers through the last days of the person's life, and signpost them to relevant services and bereavement support. Okay, this is all about support the family and carer also, not only the patient. When the patient having in his last days or end of life, and signpost, refer them to relevant services and support, bereavement support. There is an NGO I come across, the Alzheimer's Related Disorder Society of India. This ARDSI has been so far we have seen all the aspects, that what are the roles and responsibility, what you should be aware, how you will get connected with the patient, and how you maintain an interpersonal relation with the patient and the family members, how you mobilize community support, how will you take the support of interprofessional support like other healthcare professionals, whether medical or non-medical, how will you refer them to other services, how will you identify the signs and symptoms, how will you manage the crisis, how will you prevent crisis situation, how will you plan for anticipatory plan for managing any possible crisis in future? How will you involve family in those aspects? If the family care is not enough, if they are not taken care well in the family, how to move the patients, what to be done, whether the patient has to be moved to any other facilities, long term facilities, how will you proceed that? All those things we have seen in different phases of the dementia care. Now we move on to certain other aspects, like what are the role of other NGOs and other organizations. There are a lot of organizations, some important organization, this one organization I come across, ARDSI, has been working to ensure every person with the dementia gets support and care they deserve since 1992. Currently they are present in 24 cities in India and provide specialized care services for people in dementia. So coming to the conclusion part of this presentation, nurses play a key role in care of patients in different phases of dementia, because we work very closely with the patient. We are trained to assess, plan, implement and evaluate their care process, means the dementia care process. And nurses awareness about dementia care, understanding interpersonal roles and responsibilities, knowledge in advancement of care protocols and referral services play a vital role in patients outcome. Okay. So we come to the conclusion part today. So the take home message is that, first of all, we should create a dementia inclusive we should create a dementia inclusive community. For that, nurses first we should be aware about the dementia, the condition, the nursing care part. What are the therapeutic communication techniques? How do you communicate? This is most important part is communicate. I emphasize on therapeutic communication techniques. So how do you effectively communicate with the patient? How do you effectively communicate with the family members? How do you make a trusting relationship with family and family members play a very, very vital role in patient outcomes, how the patient is taken care through their dementia experience. Okay. So the take home message again here is, don't let the patient feel alone. Though they are with the people around them, they still feel alone. Please take care of them. That's it. And thank you very much for the opportunity. Thank you very much, SOA University, for inviting me to present this very off topic today on the World Alzheimer's Day. Thank you very much. If there is any queries, we'll discuss. Thank you. Over to Tanya. If there is any queries.
It's our great privilege. If you have any doubt, any questions, frankly ask to the sir. It's an open field and a golden opportunity for all of us. Students, if you have any doubt, any queries, you can ask. Hello, students.
And I just wanted to jokingly, yesterday I come across a WhatsApp message. Earlier,
I think
one
there is
person
no doubt and no
earlier one person talks
queries.
and claims that 100 people are listening, and it is called hallucination. Nowadays, it is called webinar.
For this beautiful session.
Am I audible throughout?
Hello, am I audible?
Yes, you are.
Yes, sir. Yes, sir. So it's a great honor to have been a chance to tell a vote of thanks on this auspicious occasion. occasions to World Alzheimer's Day 2021. My extend and heartfelt gratitudes to all the speakers for sharing their graceful words with us. Thank you very much, sir. First and foremost, Prabhati Tripathi. To help us. Thank you very much, sir. Next, my heartfelt vote of thanks to Dr. M. Srinivasan, who spared time from his busiest schedule to grace these occasions, and it will definitely help our students in nursing implications. We are fortunate to serve with us and to encourage in the future events. Thank you very much, sir.
Thank you for the opportunity. Allow me to leave. Thank you.
Yes, sir, sure. Thank you very much, sir. My sincere thanks to our departmental head, Mrs. Suchismita Pahanta Singh, Assistant Professor, Mental Health Nursing, to her continuous support and help. Thank you very much, ma'am. Last but not the least, my honest thank you to our organizing secretary, Mrs. Satswati Jaina, Assistant Professor, Department of Mental Health Nursing, Som Nursing College, Bhubaneswar, to arranging such a beautiful session for us. And my heartfelt thanks to each and every faculty of our department and college. Thanks to all the teaching and non-teaching faculty person to our college with all the and with the all beloved student to make the program successful and precious. Thank you very much, one and all. Our program will be continue for tomorrow at the same time, so be in the time. Thank you very much.